Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of our speakers' presentations, we will open the floor for questions. Instructions will be given at that time on the procedure to follow if you would like to ask a question. It is now my pleasure to turn this conference over to Chris Hund. You may begin.
Thanks, Chantel. Hi, everybody, and welcome to the May web conference for the National Implementation of TeamSTEPPS. Today's topic comes from the University of Washington TeamSTEPPS National Training Center, and it's on TeamSTEPPS Implementation, the good, the bad, and the ugly. So thanks for all coming out. We do have a great big group here today, so that's wonderful. I'm glad you're all here. As always, I'd like to first acknowledge the sponsors of this project, primarily Jim Battles at the Agency for Healthcare Research and Quality. AHRQ has been involved with the national implementation of TeamSTEPPS from the very start, and they do a lot of other work around this topic involved with TeamSTEPPS in primary care, long-term care, for limited English proficiency, as well as just a whole other amount of patient safety work and quality work. Also like to thank Heidi King from the Department of Defense and TRICARE. DoD has really been from the very start just the innovators of TeamSTEPPS, and it started with the military, and so we always like to thank Heidi and her team and all the people in the U.S. military that have done so much for TeamSTEPPS over the years. The project team, I'm from the Health Research and Educational Trust, and we run the National Implementation Program for AHRQ. We're a part of the American Hospital Association. We're a nonprofit research and education arm of the AHA. Our partners in this project, Impact International, which is subcontracted to us and does a lot of work around not only evaluation and measurement, but content as well. Their team really are just experts in TeamSTEPPS and have been involved since early on as well. Just a quick little bit of some commercials, as I always do, about TeamSTEPPS. The TeamSTEPPS Master Training course that we run is a 2-day training course, Train the Trainer model, and it helps you get ready to come back to your hospital or organization and train others. And it also, the other main push of it is to help you come up with a plan about how you're going to go home and implement TeamSTEPPS. I think the training course is a very small percentage of the whole experience of TeamSTEPPS. You know, it is the first step in a very long journey. And so these courses are great because they really help you sit down with experts that have been doing this, have implemented this, are working with this on a daily basis, and they help you come up with that implementation plan. Another thing that I'd like to speak about is our annual conference that is coming up in early June. There are still very few seats available. I think that we've got space maybe for only 40 more people. So it's going to be a big group, much bigger than last year's group. We're really excited. You can go online to TeamSTEPPSportal.org and click on the National Conference tab, and it will give you all the information. We have an updated agenda up there now, so you can go on if you've already registered and you're curious to see what it's all about. We have all of the sessions listed out. You can plan your day, start thinking about it. So it's going to be a lot of fun. It's 2 days in June, and there's also a pre-conference day with some training sessions, but unfortunately those are already filled up, but it's going to be a lot of fun. I hope you can come. You could always get in touch with us as well by calling this phone number that's on the screen, as well as writing this email address, and we will happily get back to you. We try to do it within 24 hours to 48 hours, and we answer all kinds of questions, from questions about very basic logistic things about how you get to a training, how you sign up, questions about our wait lists for our trainings, because right now they're filled up, but we're looking for more opportunities to do more trainings. And then we also have an email line, and we could answer questions about anything to do with implementation or the nitty-gritty of the tools. So today, just wanted to let you know is that we've got this discussion area that a lot of you are using, and we will ask you, write all your, as many questions as you want in there. We're going to try to organize them and answer them at the very end of the presentation. But our presenter also has woven in 2 areas of questions during the course of the presentation. And at those times, we're going to just do quick 5-minute question sessions where if you queue up, you could ask questions over the phone. So when that happens, we'll let you know that we're opening up the lines. All right, so right before we jump in, I do want to let you know that today's presentation will also be available on the TeamSTEPPS portal, the recording of it, as well as a transcript of it. So look for that in the coming week or so. It takes a little bit of time for that to get up, but once it's up, it's good. And then I'd like to also now introduce Kurt O'Brien, who's our presenter today, and he is the director of the University of Washington's Medicine's Organization Development and Training Department. He is also one of the master trainers who runs our University of Washington Training Center. And for those of you going to the TeamSTEPPS Conference in Dallas, he's actually going to be teaching a TeamSTEPPS Fundamentals course there. So you can meet him live and in person if you're going to Dallas. Kurt really is a fantastic trainer and a great professional. He has much experience in this, and in his career both in healthcare and working also with the Coast Guard. And he's also just an overall great guy, so I'm very happy to have him on. I think you'll really enjoy his presentation. So, Kurt, I'd like to turn it over to you, and I'll come back when it's time for questions.
Great. Thanks, Chris. I appreciate the warm welcome and all the nice comments. I often feel like we're just kind of limping along out here, probably a lot of folks are trying to figure out how can we further TeamSTEPPS in our own organizations. So again, thanks for the welcome, and thanks to you and your colleagues for the opportunity to present today. Appreciate it. And I would also like to thank all of you around the country who have been willing to take time out of your day to join in this conversation. And I call it a conversation intentionally because we're all trying to figure this out. I've been at UW-Medicine for about 12 years now, engaged with the TeamSTEPPS work for about 5. And I have to say one of my joys is actually being part of the TeamSTEPPS community because there's such a clear mission that we all bring to this work to try to improve teamwork throughout healthcare. So we're all trying to learn together, and I'll be anxious to hear some of your questions and like Chris said, to meet up with some of you hopefully in Dallas and talk more about how we can all continue to improve. So I thought I would frame this a little bit by telling you a little bit about UW-Medicine and who we are. So we are an academic health system here in the Pacific Northwest, and we're comprised of 8 different entities. 4 of those entities are medical centers. You'll see listed there Harborview Medical Center, Northwest Hospital, University of Washington Medical Center, and Valley Medical Center, which is in the south part of the city. In addition, we also have an emergency air medical service program. That's Airlift Northwest. And UW Physicians is our physician practice plan. UW Neighborhood Clinics are our primary care clinics that are located throughout the region. And lastly, the School of Medicine. So we do have a close relationship with the departments as well on the academic teaching and research side. Additionally, we have some strong partnerships here in the Northwest with the Fred Hutch Cancer Research Center, Seattle Cancer Care Alliance, and Seattle Children's. And in fact, folks from SCCA and Children's Hospital have been participants over the years in our national training program, and we've had some really meaningful conversations with those folks. Just a bit more background on who we are. Our mission is really about how can we help improve the health of the public, and we want to do that through three areas. Certainly the clinical care, but also as an academic center, bringing the research and teaching into play as well. Just to frame it again around the patient care side of things, we are the largest system in the King County area here in Seattle. You can see the data there in terms of admissions and visits and so forth. Again, this is just to sort of provide some context for who we are. So I've broken this presentation into three chunks: the early years, the middle years, and where are we going in the future. Pretty creative, I know. But as we were thinking about the title for this presentation, the good, the bad, and the ugly, it's really to share. I guess I wouldn't say that there is necessarily an ugly part of our implementation journey, but certainly a lot of things we've learned along the lines and some challenges that we've really bumped up against. And so again, my goal is just to share some of our experiences. So to start this story, it takes us back to, I guess, 2008, when one of our associate medical directors at UW Medical Center, Dr. Gene Peterson, attended a conference down in California and saw a presentation on TeamSTEPPS. And he really liked the content. He thought, wow, here's a place where, somebody's already done this thinking around designing a curriculum. And, of course, it was free, which was a huge attractor as well. And so we started digging in, learning a little bit more about the process, and that resulted in several of us, kind of in different stages, getting certified as master trainers. And we all went to the University of Minnesota for that training. So if anybody's from U of Minnesota, shout out to you guys. You got us started, so thanks for your great work. And so we started to form a little bit of a core group, I guess I would say, out here. And primarily, this is going to focus on the work we've done at UW Medical Center and Harborview Medical Center. So even though we've got the 8 entities, this really is the effort started there. We also got connected with folks down at Madigan Army Medical Center. Madigan, early on in our journey, was incredibly helpful, especially Colonel Pete Napolitano. Some of you have probably heard Pete speak in various settings, and they allowed us to come down and sit through some of their training programs, and Pete came up a few times and also consulted with us to help get us on the road. So initially we had some independent efforts going on. Harborview, actually, prior to any of us going down and getting certified as master trainers there in Minnesota, they were already implementing TeamSTEPPS, and one of the reasons for that is we kind of have an ace in our pocket here. Dr. Bill Hurley, prior to joining Harborview, was in the Army, and he actually wrote the original Med Teams curriculum. So it's having somebody of Bill's caliber is just fantastic. So Harborview had a jump on us, and then UWMC started. We started some work with the OB department. So let me talk a little bit about the specific efforts in each of those areas. So I think a key learning for us on the Harborview side was, and what made it successful and why they're still using it successfully today, is just really strong physician and nursing champions. They formed a partnership there. The senior leadership was very supportive of the effort, and really when you have somebody like Bill, and in particular one of his colleagues, Pam Turner, who's a nurse in the ED, driving this effort, role modeling it day in and day out, that really goes a long way. They put the entire department through training. They 4 hours of the fundamentals course. But really what made this stick was reinforcing it through those daily actions and role modeling those behaviors. So every time they had a chance to, debrief a situation, conduct a brief, implement a huddle, so on and so forth, they took advantage of that. Of course, they didn't get 100% buy-in, but I would say that most folks began using the skills, and I would say, if we went in there today, we'd find a very high percentage of that group actually using those skills, the TeamSTEPPS skill sets. On the UW Medical Center side, so we all came back from becoming certified master trainers and thinking, now what do we do with this? Let's figure out a way to put it to use. And so fortunately the OB department was interested in improving some teamwork on their side. So we essentially contracted with them to do some work, and we formed a change team with them. We sort of acted as consultants. When I say we, it was probably a group of about 4 or 5 of us. And that was their change team was co-led by a physician and the nurse manager of the unit. And they decided that it made sense to just focus on implementing one skill, and they chose the morning brief. And so they put a lot of effort into that. They involved quite a few people in designing what that would look like, and then they rolled it out, and it was great. They actually had the process where at that morning brief they involved a diverse group of people, but everybody had to stand. That was the rule. You had to stand. And one of the main reasons for doing that was they didn't want to turn their brief into a long. They wanted to really keep it on target and keep it moving along. The chief resident was identified as the leader of the brief, and early on they had a lot of great success. People really reported back on how critical it was to set the stage for the care day, and that is still in place now 5 years later. I would say that in some respects you could say it's been de-emphasized a little bit. They do still hold their brief. I don't think they stand anymore. I think they do sit now. But again, it has become part of their culture. So continuing on some additional efforts in those early years, we also put forward a proposal to become the fifth National Training Center, and at that time the only one on the West Coast, and I do believe UCLA has now joined that. So that was nice for us on a couple of fronts. One is that it really created an opportunity for us to have to hone our own skill set and knowledge around TeamSTEPPS and how we presented it to other people. So I guess this is our 4th year as a National Training Center, and it's been just a fantastic experience for us. So for those of you who have had a chance to come out here, perhaps some of you on the phone call and attended, thanks for doing that. We've really enjoyed it, and we've learned a lot. The other thing we did, again, like I said, we were all amped up coming back from that the Master Training Program. We decided, let's see if we can form our own TeamSTEPPS enterprise level committee. And so when I say enterprise, I'm talking about that UW Medicine health system level. And it was very much grassroots. It just organic process. We just started meeting, gathering together people who had an interest. There was not a lot of organization to it at the time. As that effort went on, we actually did create a bit of a governance structure and a team charter. But what was nice about it was it provided some space for all of us to get together and talk about ideas and try to figure out how do we actually bring this to a place of implementation and not just be a national training center and have folks running through the 2-day training program. At that point, we set a vision for ourselves, and we really wanted to shift from having teams of individual experts to having expert teams. And we still talk about that today. And as we get more into where we are now moving into the future, I'll talk a little later about how that vision is playing out. So at this point, let me do a quick pause, Chris, and we can take some questions.
Sounds good. Chantel, if you would like to open up for the question and answer queue for the next 5 minutes, and we'll see if there's anybody with any questions.
Thank you very much. Ladies and gentlemen, at this time, we will open the floor for questions. If you would like to ask a question, please press *1 on your touch-tone phone now. Questions will be taken in the order in which they are received. If at any time you would like to remove yourself from the questioning queue, please press star 2. Once again, to ask a question, please press star 1 on your touch-tone phone now. Our first question will come from Barbara Burke.
Hi, can you talk a little bit about your experience with simulation in TeamSTEPPS? I understood that that was to be the focus of this conference.
Sure. Thanks, Barbara. I can talk a little bit about simulation, and as I move into my next section, I will chat a little bit more about how we've used simulation. So one of the partner groups here within UW-Medicine is a group called ISIS, which stands for the Institute for Simulation and Interprofessional Studies. Dr. Brian Ross is the executive director of that program, and so Brian got on board very early on with his team. And in fact, now we actually run our national training courses through ISIS and the Sim Centers. And so we always thought it made a lot of sense to really focus on application. And so in that spirit, really looked at how could we create simulation experiences within training, but also how could we use existing training, for example, codes, and weave TeamSTEPPS skills and knowledge into those training simulations, and that's worked really well. It's really given us a chance to highlight not just the clinical skills that we need to reinforce, but also the communication and, as Brian likes to say, teamsmanship skills. And again, hopefully that helps a little bit. And I'll be talking a little bit more in my next section about how we've used simulation.
Thank you. Our next question will come from Catherine Wynn.
Hi. I wanted to know, you mentioned the College of Medicine that you partner with, but University of Washington also has a very strong College of Nursing. Do you also partner with the College of Nursing for TeamSTEPPS training?
Yes, we have some involvement with the School of Nursing, and in fact, one of our trainers, Ross Ermentrout, does a TeamSTEPPS presentation at the nursing school. Additionally, Brian Ross with the ISIS group has a few folks on his staff who have affiliations with the School of Nursing. So yes, we definitely have that partnership in existence.
Okay, thank you.
Thank you very much. Once again, as a quick reminder, if you would like to ask a question, please press star 1. Our next question will come from Sandra Gorski.
Yeah, hi. I guess I'm going to ask a kind of a basic question. One of the things that you said that was successful in your early years was getting leadership support for this initiative. Can you give any advice to those of us who are challenged in getting that kind of buy-in from leadership? What's a good way to try to get that started?
That's a great question, Sandra, and I probably don't have enough time to fully address that one. If it's okay with you, what I'd like to do is hold your question and address it in these next two sections of my presentation, because that has it has implications depending on whether I answer that from the perspective of the large system and leadership support versus at a specific department, team, or unit level leadership. Will that be okay if we get into it then? And then if you have additional questions about that, you could follow up at the end. Will that be okay?
Yeah, sure, of course. Thank you.
Great, thanks.
Thank you. Our next question will come from Judy Ellsbury.
Hello, how are you?
I'm well. How are you, Judy?
Fine, thank you. My question is about getting my instructors to be master trainers, and we're in the military here at Fort Irwin in the Mojave Desert. Is there any military people on the line? And I guess I chimed in a little late, so I apologize for that. But this is the University of Washington Master Trainer course that's been full for a while. I guess my question is, what makes somebody a master trainer? Is it attending the 2-day course at U Washington, or through the military network, which I've attended already, or I teach the course myself and therefore I make them master trainers? What is the process that you're using for that?
Chris, do you want to take that question?
Well, sure. Yeah, definitely. There's nothing makes the University of Washington or any of the AHRQ national sites to be the one and only place that can allow somebody to be considered a master trainer. So definitely, if you utilize the material that's been produced by AHRQ to teach the course to others, if somebody is willing and able to then teach that to other people, they would be considered master trainers. I know with the military, and you said that you were with the Army, right?
Yes, sir.
Okay, I know that with the Army, all the trainings that go through MedCom and through Phyllis Tours Group, definitely they do some pretty innovative things and definitely count, I would assume, as master trainer courses within the military, for sure.
That's correct. Yeah, we love Phyllis at MedCom. She squares us away with everything.
Great.
And I have directed my master trainer questions towards her. I was just wondering, relative to sending people to Washington versus the military, it would be equivalent, right?
It would be, and actually the national training centers at places like Washington and other places are focusing more on civilians, and then the military trainings run through the different branches.
Excellent. Thank you for answering my question.
No problem. Well, Kurt, would you like to keep going? I know we have some sections for questions later on.
Absolutely.
Great.
Thanks, Chris.
You're welcome.
All right, so I'm going to shift into the middle years. And at this point, several things were happening. We were trying to figure out, okay, how do we had a lot of excitement and energy about TeamSTEPPS and team training in particular. And we were trying to figure out, so how do we really make this possible? And we started just sort of naturally, I guess, moving toward a bit of a consulting model where we were working with individual areas. So you'll see here on the slide, Harborview burn unit and interpreter services are two areas that we worked with, and at UW Medical Center, the ICU and the ED. And so that was quite a process for us. We actually worked to assess their readiness for bringing this to their areas. We wanted to make sure there was leadership buy-in. So Sandra, this starts to get back to your question. We would actually sit down with folks and have a conversation with them and talk about the effort that would be required on their end and who would need to be involved and how we could help support them, but we couldn't implement it for them. They had to do that themselves. And we found that those conversations were really helpful for folks in making decisions about, do I go forward or do I not go forward? A few other things that we did, we did introduce 4 hours of TeamSTEPPS training for all incoming residents. And so this is where we started to get into that partnership with the School of Medicine and the GME side of the house. And so we've been doing that for 2 years now, and that's really been successful. So where we have had some challenges, as you might imagine, is so now the residents are getting this training, but they're moving into an environment where the folks they're working with side by side have not necessarily had TeamSTEPPS training. So I'm going to come back and address that when we start to move into these future years. But again, having that in place has been huge. We do a short introduction to orientation to TeamSTEPPS for new employee orientation, for staff orientation. We have staff orientation every 2 weeks. And so it's about 20 minutes that they get. So again, it's not in depth, but it's kind of dipping the toe in the pool and letting people know that this is how we think about team training here at UW Medicine. A third thing that happened was we also, at Harborview, decided they wanted to attempt an organization-wide dosing strategy. And we thought that the way to start that would be choosing a couple of skills and putting that out there. And they wanted to focus on the cuss and to challenge rule as the two skills to introduce. And it was great to have that experience from a couple of standpoints. One, we got to see what was it really like to have to logistically put together this type of training and get it out to folks. The other thing we learned is that just because we did a training for the masses didn't mean that we saw behavior changes on the job. And I'm sure I'm speaking to the choir here. The saying I like to use with this, back to my Coast Guard days, I spent 12 years active duty Coast Guard, was the spray and pray methodology. You can spray them with the training and pray that it sticks, but it doesn't necessarily guarantee that you're going to get that change in team behaviors or communication behaviors. But again, it was a great effort for us to go through, and again, just getting the word out about TeamSTEPPS. A fourth thing that we did, and this was on a much smaller scale, was we had a surgeon in otolaryngology who was interested in using TeamSTEPPS with his team, his surgical team. So we met with him, Dr. Al Marati, and we actually went in and we spent some time observing his cases. And that was great because we could really pay attention to the teamwork, the team communication skills. And what we did after that observation was we met again with Al and his RN3 and shared those observations and talked about what would be a skill or two that we would like to introduce. So in this particular case, we noticed that his team did a really good job with call-outs, but there wasn't a lot in terms of closing the loop with those checkbacks. And so what we did was, rather than sit down and do a 30-minute or an hour training on those specific communication skills, we went back down into the OR. We met with his team just prior to going into their case, and we literally did about 3 minutes of an example on what a checkback is. And we said, hey, this is what we want to focus on today, and we went and they did the case, and we observed, and we did a debrief afterwards. And it was cool because we did actually see people paying attention to and using that checkback process. So unfortunately, we haven't done a lot of follow-up with that. Al was kind of our champion, and it's easy to get distracted and move on to other things, but we still hold on to that as an example of what's possible in terms of some of that just-in-time training. So let's see here. What else do I wanted to mention here? In terms of going back to the Harborview burn unit and the UW Medical Center ICU, and back to Sandra's question about that leadership buy-in, in each case we had a strong partnership at those particular units between the physician leader and the nurse manager. And that's really, in my mind, what led to successful implementations in those two areas, along with being able to provide them some consulting support along the way. On the Harborview side, colleague Ross Ermentrout was absolutely instrumental in helping the burn unit move forward with their work. They've been a few years into it now, and they actually see the difference in the results of their patient satisfaction results, for example. And the ICU here at UW Medical Center, same deal. They chose to really focus on implementing SBAR, and they went full out on that. And so this idea of choosing one tool, one or two at the most to start with, we found to be pretty useful, rather than trying to say, hey, implement it all at once. All right, I'm going to move along here. All right, so I already talked a little bit about how we included TeamSTEPPS in new employee orientation. And again, this is really emphasizing that we were able to standardize some of our processes. That's an example. The resident training is an example. We continued our involvement at the national level, as I mentioned earlier. And again, that's really been key to our own knowledge gains, I would say, around TeamSTEPPS. One of the benefits by being a national training center is we get to learn from all of the folks coming through and hear from their experiences and what they've tried and what's worked and what they've struggled with. And so this is where I wanted to highlight a little bit more further development of simulation. Certainly within our national training courses, we decided to bring in simulation as a way to I guess, highlight and drive the point home more about getting these skills out there. So as opposed to, when we went through, again, 5 years ago, there was a teach-back session, And so what we did was we started giving people the chance to choose a skill and then to practice that and videotape it. And just a short videotape. And we taught them how to do a quick storyboard and so forth. And this is where I'm certainly not a sim expert. And got Tulane is certainly recognized for their expertise as well. But I learned the difference between high fidelity and low fidelity simulation, for example, and that there's a lot you can do, powerful things you can do with low fidelity simulation. Low fidelity is simply using the resources at your disposal. You don't have to have, a mock-up OR that you can go into with the mannequins and so forth to do simulation around TeamSTEPPS. So that's been a great learning for me, and it was really fun to see people just grab some props that were laying around in the room and come up with just really pertinent examples. And so we still carry that on today. And our hope is that people are taking that back with them and using some of those strategies in their implementation. One other thing I'd add is that we also did use some scattered use of the Culture of Safety survey, use some data from that, and we did, with a couple of groups, use the original TeamSTEPPS questionnaire, the 55 questions. But I have to admit, we haven't done a lot with those more evolved TeamSTEPPS questionnaires recently. So then, of course, the issue of resources comes up, and this comes, I guess I would address this as in terms of that larger leadership buy-in. There's nobody that I would talk to here at UW-Medicine that would say TeamSTEPPS is a bad idea. Everybody believes hey, if we can improve communication, get the team working more cohesively, that is all good stuff. And so with our TeamSTEPPS enterprise committee that I told you that we formed, we developed a proposal. After we formed our charter, we did develop a proposal to take to executive leadership. And within that proposal, we described the work we wanted to do, why we thought it would make a difference, how we were going to measure it. We did it in an SBAR format. And we also had a resource ask in there. We knew we couldn't continue to do it on just the backs of volunteers. People were already feeling pretty stretched. And so we did ask for some new resources, and unfortunately this was the answer. And I'm guessing many of you can resonate with that. And I didn't put this slide up here in any way to, as a dig at leadership. It's not that at all. It's just to recognize the reality that we're all facing. It is getting tougher and tougher in healthcare right now, and we're having to figure out how do we make do with the resources that we have, or even in some cases, reduced resources. So in that environment, what do we do to figure out how to keep this moving forward? I'm not here to tell you I've got a good answer to that, but I think through this community, the TeamSTEPPS community, we share our stories, we share our examples, and that's how we start to get better. So again, pointing out to this reality testing piece, we do have some pockets of excellence, the Harborview Emergency Department, the burn unit at Harborview, the UW Medical Center ICU, and so forth. And we also have pockets of interest, but we found so what happened in the middle years, so this is part of the bad, ugly part of this conversation, is folks just didn't feel, who originally had a lot of energy and excitement for doing this work, found that they couldn't continue to maintain that. And so that group has shrunk. And so there's a few of us that are still, trying to carry this on, but it really does come back again here to these persistent resource challenges. And so we're right now, actually, we're in conversation with folks trying to figure out how can we move forward, resource this up a little bit, and take our implementation efforts to the next level. And so I'm going to pause again here, see if there's some more questions, and then after this I will talk about what do those efforts look like. I'll explain a little bit about some activities that are going on right now that are getting some executive leadership more engaged, which is good. So I'll talk about that after this pause here. Maybe about 3 minutes, Chris?
Sounds good. Chantel, let's open it up for 1 or 2 questions then.
Great, thank you. Once again, ladies and gentlemen, if you would like to ask a question, please press *1 on your touch-tone phone now. Our first question will come from Pam Brown.
Hi, this is Charleston Area Medical Center, and we have been implementing this for about 3 or 4 years now. Mostly, and I heard you talk about the ORs, the EDs, operational procedural areas. And my question, and it could get kind of complicated, I'll try to state it directly, is have you moved this to the medical surgical units? I can see teams and ICUs and everywhere, and if you did you just choose something for them, or did you have tool workshops and let them choose the tool, or did you select tools? Would you just speak to that if anybody has done med-surg?
Yeah, that's a great question, Pam. Well, I can tell you what we've used regardless of the unit, and that is to have them form a change team right out of the gate and be real explicit about who we would recommend be on that team. So that they've got skin in the game, basically. And then once they have that group together, then we'll sit down with them, and sometimes we even expand that group. And in some cases, we've taken them through a 2-day training. In other cases, we've taken them through, the 4-hour fundamentals. But once we spend some time exposing them to the basics, the fundamentals of TeamSTEPPS, and then we allow them to choose the skill they would like to implement based on their environment and what they've got going on. I'm sorry?
What the gap is in their environment, like it's a handoff or where they're more at risk.
Exactly. The other thing that we've done is we took to calling these skills and dividing them up into 100, 200, and 300 level skills. So it's not, I don't know about your experience, but it's not uncommon for us to have a situation where somebody will come to us and say, hey, we really need to implement CUS because we need to make sure that everybody on that care team feels empowered to speak up. Well, we consider CUS to be at that 300 skill level area.
I agree.
You can give people that training, but it doesn't make it any easier for people to speak up. So we try to step back from that and say, well, what if you started with a brief or a huddle or an S-bar or just call-outs and check-backs and start the process there.
Thank you. That's very helpful. Thank you.
You're welcome.
Thank you. Our next question will come from Janice Smith.
You noted that you had done some things with new employee orientation. Could you expand on that a little bit? And then my second question is, with these 300-level skills that you talk about, like CUS, have you done any kind of scripting to role play with those individuals to help them learn to model that behavior and implement it? Because one of our challenges have been, once the skill is taught, if there are not role models in the area that can assist those weaker staff members that have more difficulty speaking up, that's where we get our waxing and waning.
Yeah, great questions and points there, Janice. So first, in terms of the NEO question, I call it NEO for short for New Employee Orientation. It's really basic. But again, about 4 years ago, we decided if TeamSTEPPS is the language we want people to, hopefully be aware of and using, then we need to start introducing it right out of the gate. So again, we combined it with our patient safety presentation. So the patient safety officer will talk about TeamSTEPPS in their presentation. And again, it's not intended to be an in-depth look at TeamSTEPPS. It's really 15, 20 minutes. Share some stories, give some examples, and that's pretty much it at that level. And then we hope that people will go back to their own areas and maybe ask some more questions about it. In terms of the 300 level skills and that idea of scripting, that's a great point. Couldn't agree with you more. And yes, when we're working with a group independently, we absolutely try to build in those opportunities to practice. I'm trying to think if we've actually used, where people have a script that they use. I'm not sure we've done it that way. I've written that down. That's a point I want to bring back to my team. I would say what's been more key is leadership role modeling these behaviors. So, for example, if you have, the leader of the team, or even at the beginning of the brief in the morning, say something to the effect of, hey, let's introduce ourselves and let's make sure that, if you see something, be sure to speak up, that really helps set the tone. I remember a couple of years ago at in one of our national training classes, we had some folks from Seattle Children's, and one of the physicians had spent some time on a helicopter, medical air emergency services, flying in a helicopter, and he talked about how impressed he was in one particular instance where the pilot set the stage at the beginning and said, hey, look, I can't see everything. I really depend on you folks as the crew to call things out. And it turns out in that particular flight, they were flying in, I think it was into a schoolyard, and there was a wall, a concrete wall, and the pilot didn't see that the tail rotor was getting ready to hit it. This particular physician called it out, and the pilot was able to respond. So that's a great example of leadership, saying, hey, I expect everybody here to follow this.
Kurt, would you like to continue on with the end of your presentation?
I would.
Great.
Thanks, Chris.
You're welcome.
So now, where do we go from here, moving forward? This is certainly a constantly evolving question for us here. And one thing that happened last summer was the School of Medicine participated in a nationwide survey where they asked medical students a series of questions. But some of those questions were around how they perceived they were being treated in their areas. And UW School of Medicine had some pretty low scores in that regard, and it really caught the attention of leaders. Almost 3/4 of the medical students here said that they felt they had been mistreated at some point. Now we're talking about felt like they hadn't been listened to, or that their input was disregarded, that kind of thing. So again, that really got the attention of executive leadership, and we were able to give some presentations to clinical chairs, for example. A physician in the dean's office actually has been a huge proponent of this work, Dr. Larry Robinson, and so it really has elevated, in some regard, the need and the importance of team training. So as a result of that, there's been a bit more of a call for TeamSTEPPS training for faculty and staff. We're kind of right in the middle of this. There's been some follow-on conversations, even though the survey results came out at the end of last summer. It's still, figuring out who's ready to do this, and how are we going to resource this to meet demand. So in other words, if we were serious about, okay, let's put all of faculty and staff through this training, well, we're talking about several thousand people. Are we really prepared to do that? And from a resource standpoint, the answer is no. So then we have to start looking for other alternatives. And one decision we made here locally was to really leverage this consulting approach. And so again, this is just here through our lenses at UW Medicine, but we've seen success with this consulting approach. And so what our goal here in the next few months is to actually create a more robust structure to follow this consulting model. And what that looks like is creating a bit of a stronger governance structure at the ISIS level. I talked about our SIM Center. And then creating a position who is sort of, I guess I would call like an assistant director position, to really help manage where are the opportunities to conduct TeamSTEPPS implementation, and then create a pool of consultants and trainers that we can draw from to then go into these areas and work with them for some set period of time to implement their own goals around TeamSTEPPS. And, I'd also have to say that when we go in and work with these units, we really don't talk about it in terms of, oh, let's do TeamSTEPPS. We talk about it in terms of, let's help you improve your team communication and your teamwork, and the model and methodology we're going to use to do that is TeamSTEPPS. So again, like I said, we're kind of right in the middle of this. The resource piece is still a challenge. Just last week we were having some conversations with folks, and the reality is there's some real budget challenges out here right now. So we're going to have to, again, get creative on how to form up this structure. The other thing is I was talking with some of my colleagues about this presentation, getting some of their feedback. Ross Ermentrout, who had mentioned earlier, said, you know, we really need to move away from this view of being, this is one more thing I have to do, i.e. go to this training, to this is a way we do business. And again, that goes back to our vision of wanting to really shift from being a group of individual experts to expert teams, and that continues to be our goal. One resource that we are seriously contemplating using to help us with this is the book Switch. Many of you may be familiar with that. If you're not, I'd highly recommend it. Again, the title is Switch. It's by the Hale brothers, Stanford and Duke professors, and they put forth a fairly nice and simple change model. And the metaphor is riding an elephant along a path. And what's nice about it is it engages us in a change methodology from the perspective of how do we set a direction and move in that direction? How do we motivate ourselves and others to follow that vision? And then how do we set some critical moves along that path to help make sure we achieve that vision? And in our mind, TeamSTEPPS becomes the skills, those tools, these skills we talk about help us shape that path, become the critical moves that we need to make to help achieve this vision of becoming an expert, having expert teams. So that's where we're headed. A lot of work still to do. We'd love to chat with more of you about this at Dallas if you happen to be there, or in other forums. I know through the TeamSTEPPS portal, for example, maybe we could have some electronic communication, or can reach out via phone. But again, that's one of the joys I have with this particular community is we're all trying to accomplish the same thing. I included a few pictures here just to show how we leverage simulation in our national training workshop. In this particular photo, you'll see we actually, right in the middle of class, we have somebody simulate having a heart attack, and so everybody's got to respond. It's great because it creates a little bit of excitement and anxiety in the class, but we can loop it all back to the skills that we're teaching. Instead of doing the paper chain, we use Legos as a way to get folks working together in a team, and they have a particular type of tower they have to build, and we run 3 different iterations of that. If that's something anybody's interested in, you can let us know, and we'd be happy to share our instructions for how we do that. And then another way we've introduced, I guess like Emerald would say, bumping it up another notch in terms of the simulation is we'll actually simulate a fire. So we'll have a situation where we simulate the fire, the smoke comes out, we actually have to tell the building to turn off the smoke alarms for a few minutes. And then we ask people to respond and move a patient out of a patient room and out of the building. So again, just some other ways that we've looked to try to leverage some of that simulation. And I think,
Kurt, as we're getting towards the end here, there have been a couple of questions around your comments of the different levels, the 100, 200, 300 level type of, the tools from the different TeamSTEPPS principles. So I was wondering if you have a general thought on that, what those are, or if it's something that's maybe thought of, unit by unit or hospital by hospital based on where they are in their journey.
Right. No, we sort of have it, and of course I didn't bring with me my my cheat sheet on that. For the 100 level skills, we talk about things SBAR, briefs, huddles. Not the debrief, though. We put that in that 200 level category. Let's see, and introducing the idea of shared mental model. Those are at that 100 level. When we move into the 200 level, we start. That's where we will start to talk about the idea of doing a debrief. We will also talk in that section about, I guess, building onto the shared mental model in terms of situational monitoring, situational awareness, and really focusing in on those areas. And then at the 300 level is where we really move into helping people have those difficult conversations. Sometimes we'll will include aspects of crucial conversations and the skills from that work to help people move to have constructive conversations when there's disagreement.
Thanks. That's really good, Kurt. That's helpful because I know that we've talked about that before, and but I wasn't sure your exact thoughts. So that's great. Thanks. I know we're getting close to the top of the hour here, and so I think there's a lot of people in the queue with questions. I think we have time for one question, Chantel, maybe two. For anybody who doesn't have their question answered, feel free to drop us an email at that AHRQ TeamSTEPPS at AHA.org, and we can address your question there. But Chantel, is there anybody in the queue right now?
Thank you. A quick reminder to ask a question, you may press *1 on your touch-tone phone now. We do have a question from Cicely Wilkinson.
Hi. You spoke about strong physician buy-in. Could you tell me what methods did you use to get physician buy-in?
Sure. Usually it would start with just a sit-down meeting. If a group came to us and said, hey, we think we're interested in this TeamSTEPPS work, then we would sit down and ask them, tell us why. What's going on in your area that is an indicator to you that you think you need to improve your teamwork and communication. If we get signals back that the leadership may not be, quite there, then we just have an upfront conversation with them about it and say, is this the right time, or do you need to wait a little bit longer? So really for us what's worked is just having that upfront conversation. That's been really effective.
Thank you.
You're welcome.
Thank you. Our next question will come from Joseph Paulo.
Hello. I was listening to your challenges around budget and resources, and I was wondering if there's quite a few papers out there that have been published on by using TeamSTEPPS in simulation, the reduction of morbidity, especially in perinatal. And I'm wondering, have you had an opportunity to tie that perhaps to the reduction in exposure to litigation, and could that then provide dollars or resources, free up dollars to provide resources so that you could actually build that into the culture of your healthcare system?
Right, that's a great point, Joe. And actually, yes, we have done that. And again, nobody would say that TeamSTEPPS is a bad idea. I think there's just so many different competing commitments. People are just trying to figure out where do they put all that energy. And so, yes, we have tried that. In fact, just recently we had a situation here where we know that a check back didn't occur in a situation that if it had, it would have saved us some headache and heartache down the road. And so absolutely, and we continue to I guess beat that drum and try to make those points.
Thank you.
You bet. Thank you.
Well, thank you everybody for coming in today. In the interest of time, it is 1 o'clock Central Time here where I am, so I know that that's the end of our time for this webinar, but please feel free to come on and ask questions at the National Conference if you're going to be there. Make sure to drop us questions via email if you have any at the address I provided before. And then you could also go to the TeamSTEPPS portal and find those addresses there. Our webinars we're going to take the month of June off because we're going to be at the National Conference in June. We're going to make sure that we post all of the material from the National Conference afterwards so you can look at people's slide decks, see what was presented on. We're also going to make a few recordings available. 1 or 2 of the sessions we'll video and make sure to get them up on the portal for people to watch if you can't come. And like I said, we're taking June off, but July 10th we're coming back, and that particular presentation will be on simulation. And then moving forward, we have 2 more that we've got scheduled and ready to go and that you can go onto the portal and register for. But that's all we have today. So Kurt, thank you very much. And everybody who joined in, all 365 of you, thank you very much as well for coming on in and being with us today.
Great. Thanks, Chris, and thanks, everybody, for participating. Hope to see you in Dallas.
Thank you very much. Ladies and gentlemen, at this time, this conference has now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you.